Yeah, wondering.
Yeah, yeah.
I was going to say my sister's 10 coaches.
Welcome, everyone. Sorry we're getting started a little later than usual, but we wanted to give our late arrivals a little bit more time to get here to join us for these very important presentations. I want to thank particularly RAND Corporation for hosting us here, and I would, for those of you who don't know me, I'm Hattie Hanley. I'm the director of the RightCare initiative. We have been operating statewide since 2008, and we are a collaborative across the great academic institutions of California and the great health systems of California, as well as with public health. So we have some amazing minds here in the room today, and we will have more trickling in as the traffic allows folks to join. So I know what an effort it is to gather every month, but I want to say it's a powerful group of people who are able to make real change for the public, and we have made real change. And I see that one of our biggest change makers, who was sitting back there a moment ago, has had to step out for a moment. But needless to say, it is impressive what can happen for the public good when great minds come together and put shoulder to the wheel. So we have seen in both our American Journal of Managed Care article in October of 2017, and then recently just last month in the California issue of Health Affairs, that in our initial pilot project, which the gentleman who just walked in the door helped us with in San Diego, Dr. Scott Flynn, former undersea medical officer with the Navy, who we are very fortunate has joined the civilian medical workforce to bring some of his absolute dedication to making things happen, even if they're not easy, to bear for the public good. So that public good has equated to something very concrete. In our initial community in San Diego, acute myocardial hospitalizations fell by 24% in our first 4 years with Scott Flynn's help. And that progress has sustained at a 22% decline relative to the state progress. That has added to 3,826 fewer acute myocardial infarctions. That's real concrete lives, and those are just the ones that made it to the hospital. So as we all know, a lot of folks don't make it to the hospital. So Carol Zaher here, raise your hand, Carol, because we all want to get to know each other, is a cardiologist who has dealt with a lot of sudden cardiac death. Those are the folks that don't make it in to those numbers. So we know that 3,826 fewer families suffered the loss of a loved one thanks to people like yourselves, and including yourselves, putting your shoulder to the wheel. So one of the people who put amazing shoulder to the wheel is Dr. Alan Fremont, MD, PhD, who as soon as he learned of this project, he's a RAND researcher who can't be with us today, but his soulmate and fellow RAND researcher will talk with us a little bit about what it has meant to him. He has been the backbone of our RightCare initiative, always standing for, Hattie, we have to have the data. We must have the data, and we must have the data on a much more regular basis than what the state produces. And I would fight with him, but of course he was right. And so he was the lead author on this health affair article that took the data and demonstrated how it has positively impacted families. So Chloe Bird, senior research analyst and leader here at RAND, who's a leader in women's cardiovascular disease, is just going to say a few minutes to welcome our group and encourage us in this work.
Well, thank you all for being here. I just wanted to say how, one, Alan really appreciated, we both did, the acknowledgement of his work at the recent meeting, and of the successes in San Diego and how committed we are to seeing through the possibility that bringing together and setting up a data group here can achieve results in reducing cardiovascular events in Los Angeles, because we've demonstrated the potential savings out of that kind of work. And it was very striking. I hadn't thought about it that much until the event the other day, that his work on this started with the stimulus grant, the NIH stimulus grant, which they obtained after his cancer diagnosis. And so at the same time that he started on this path in dealing with his own lung cancer, he started on this path, and all of the difference that has happened in this work has happened out, in the face of the cancer. And I would argue he's here because of this work. This is why he trained. This is what mattered to him about going into medicine in the first place, being able to do something that could improve care and outcomes and reduce disparities. So I want to acknowledge you on behalf of myself, on behalf of Alan, on behalf of RAND, for being an exceptional group that's willing to come together to make that kind of difference, to do things somewhat differently in a way that we've shown can improve care. So thank you.
Thank you so much for hosting us, Chloe. So you'll introduce Tony to do the ADA announcement? Yeah. Oh, okay.
I think those of you who are regulars here will remember Dr. Tony Quo, who's going to come up and give us a brief talk. He's the director in chronic disease and injury prevention for the LA County Department of Public Health, and really focused on population health, which is basically a big subset of what we really want to do here at the RightCare initiative. So.
Thank you, Carol. This actually is very quick. I just wanted to make an announcement. In the last several years, we've actually been working with American Diabetes Association to kind of help them kind of rethink how they are trying to deal with the issue around diabetes. And I just want to make an announcement that on October 30th, they actually are hosting a CME event and conference at the Cathedral of Our Lady of Los Angeles. That's actually downtown. It's a very nice place. And I think the CME credit is like 6.0, but basically it's for primary care physician or any other physician, and they're trying to provide newer updates to both diabetes management, but I think also for the first time, they're also looking at ways to provide some of the newer information around pre-diabetes management, as well as also some of the other risk factors like obesity. So that's it. I'm happy. I'll send Hattie, who can probably send the link around if you know of any of your physicians or anybody who will be interested. So thank you, Carol.
So the upshot of that is that there's going to be some very substantive diabetes, continuing medical education on and put on by the Diabetes Association with the encouragement of the Department of Public Health through the leadership of Dr. Tony Quo. So if you can get your frontline practitioners to go to that, I will send you the link. So thank you, and thank you, Dr. Zaher, for doing the introductions.
Okay. Well, as Hattie gave a nice description of the initiation of the RightCare initiative and our goals, and I think we briefly mentioned in a prior meeting how, I'd say in the last maybe 2 months or so, we've developed a subcommittee on heart failure. Since a lot of coronary artery disease that isn't treated may end up as heart failure patients, we've decided to take a look at that and see if we can incorporate heart failure as an avenue of intervention with this group as well. So today we're actually going to focus on 2 discussions of heart failure. And today is the Cedars reunion day, which is very nice for me. I can relive some of my old stomping ground stories there. But don't tell any of those stories now, okay? You just keep them to yourself.
There's some good ones.
It does give me great pleasure, though, to welcome Dr. Norman Lepor. We did share some time at Cedars. We won't tell you how long ago, but it was, we'll say the recent past. And Norm has had quite a distinguished career since I last saw you. I'm really impressed, Norm. He's, as mentioned here, the past president of California chapter of American College of Cardiology, clinical professor of medicine at Geffen, UCLA, part of the Cedars-Sinai Heart Institute, director of research at the Westside Medical Associates, and yes, co-director of the Westside Medical Imaging Department. I didn't see the U.S. News and World Report article. I'll try to look that up, though.
I paid enough for it.
Oh, so it's like Google, if you pay enough, you get high on the list. And, you know, wide experience in all aspects of cardiology. Written papers in the noble journals of the cardiology world, and obviously done a lot of procedures and imaging, and I think you just bring a world of good expertise to this conference group. So with that, I will welcome Dr. Lepor.
Thank you very much. It's really a pleasure to be here. I've actually lived in Los Angeles, 30 plus years. It's the first time I've actually snuck through the gates of Brand Corporation. So now the question is, will they let me out? So my background is really as a trained interventional cardiologist, but my practice has really morphed into imaging, which I think is a really important topic because it allows us to upfront do a better job of risk profiling our patients, much better than the types of risk profiling you get with some of the criteria such as Framingham and Reynolds. And also, even more recently, I've become very involved with some of the new innovative medication for the treatment of dyslipidemias, and most recently, actually, I've been very much involved in the issues related to cardiovascular disease and diabetes. And I think that this is perhaps a very timely subject because we now have, as of 2015, drugs for diabetes that actually reduce cardiovascular events, which is why I think it's so important with the discussion of diabetes that we really look at changing our paradigm, our algorithms for approaching diabetes, actually away from a fake biomarker, A1C, into utilization of compounds which now have a robust amount of evidence of rather profound reductions of cardiovascular events. That seems to be actually A1C independent. So I'm not going to have to go over the issues of defining diabetes, but this is really the result of relying on glucose, but actually we know that diabetes represents a plethora of abnormalities, metabolic abnormalities. 7th leading cause of death in the United States, and mortality rates are 50% higher in adults with diabetes than without. Most of these patients share a variety of cardiometabolic abnormalities, including hypertension, dyslipidemia. And there's something about the diabetic condition, you know, that, and we postulate on a number of mechanisms, many of which are related to lipids and hypertension, and some modest component related to hyperglycemia, but definitely It's a syndrome of a sick population of patients for the most part, but even within diabetics, there's heterogeneity in terms of risk. And there's something about diabetics, higher incidence of most cancers, a higher incidence of a whole variety of non-vascular related mortality. So there's something about the diabetic patients which really predisposes them to a whole range of illnesses above and beyond coronary vascular disease and what you'd expect from the development of chronic kidney disease and the other ailments commonly associated. So we see here, looking at obesity, hypertension, and hyperlipidemia, which is very relevant to what Hattie talked about this earlier, and Carol, in terms of all these conditions that come together to really constitute really the diabetic syndrome, I would say. You can see the majority of patients have a variety of comorbidities, and when we need to attack these comorbidities individually, much better than we're doing at the present day. So, just so you know, my topic has been changed 3 times.
Yeah, over a long period of time.
Yeah, over a long period of time, and I just found it actually changed today. So if what I speak about doesn't jive exactly with the topic, I think it's still interesting, and you'll still learn something. So Hattie, thanks for keeping me on my toes. I have to check my morning emails actually earlier. So the issue of imaging, again, does a great job of really profiling and individualizing, or what we call personalizing, which will be PC, right? I'm not a very PC person, for those who know me, but we'll use some PC concepts. Personalizing care. Well, how do you personalize care best? You get to know the patient better. And how do you get to know the patient better? You get to see what's going on the inside. And that's where imaging plays a role, and something which I wish the payers would allow us perhaps more latitude in order to better identify those patients. Because not all diabetic patients have similar risk. And the question is, can imaging help to stratify risk so we can resource allocate? Let's pile on the therapies that work on the patients that we think will benefit the sicker patient, the ones with more morbidity, and the ones that, for some reason, genetics or other environmental factors, they don't have the same risk, and therefore we don't have to get to the same LDL perhaps, or the same lipid levels and such. So I'm going to talk a few minutes about the coronary calcium score, and then talk a bit more about the coronary CT angiogram. Coronary calcium scoring, I think, is a very, very useful technology, and it can be used in a way that's economical and appropriate. So it really defines the presence of calcified plaque. So calcified plaque is like the part of the iceberg you see sticking out of the ocean. Not everybody who has calcified plaque has non-calcified plaque, and there are patients who have non-calcified plaque who don't have any calcified plaque. But the presence of calcium, calcified plaques, is a sine qua non of atherosclerosis. You have an abnormal calcium score above 0, you have coronary atherosclerosis. It's really been shown to add significant information to the risk scoring we do clinically. Once it's abnormal, it's kind of like pregnancy. You're pregnant, you have atherosclerosis. There really is little need to keep repeating these tests. We've reported a conversion rate from 0 to above 0 of about 3 to 4% per year. So if the patient has risk factors and we have a 0 score, this is a patient I may bring back 5 years later to see if they have converted. There's a pathophysiology. So really what is the development of bone? This is really bone that develops in the wall of the arteries, calcium phosphate, and it's really produced by activated macrophages, which morph into osteocytes. So you actually have cells that secrete calcium phosphate. And so the arteries are kind of like chalk, okay? Especially those that are highly calcified. This is an interesting slide, and I'll bring you through it in a way that I think you'll understand. So we have age, and this is the prevalence of calcium and event risk. And what we see here is when you're young, we don't see a lot of the calcium in the arteries, even if you have plaque. It's kind of in a way, it almost goes along with aging, and it increases with age. So it's very unusual to see calcified plaques in young people. So we really don't get into using coronary calcium scores until, as a male, you're in your 40s, and generally in women once they approach the menopause. And you can see with age that the prevalence of calcium increases to the point probably there are very few people in their octo or nonagenarians who don't have any calcium. And certainly 10-year risk goes up as patients get older, not just because of calcium, but as you get older, your 10-year risk. And I think this provides an important point, and I'd certainly like to hear your response. In younger people, it doesn't make sense to calculate a 10-year risk. You want to know a lifetime risk, right? You want to ask a 30-year-old, what's the chance you're going to live to be 40? It's probably going to be very, very high in terms of mortality, morbidity from cardiovascular disease. But I actually want to know that 30-year-old, what's his lifetime or her lifetime risk of developing disease, because that will be something I will want to intervene on. So I think what's important in younger people, we really want to look at what we call lifetime risk versus older people, looking at people perhaps over 45, looking at the 10-year risk. This is what a calcium score looks like. It's not very mysterious. We're actually looking for bone in the wall of the coronary artery. No contrast is needed for this test. You're probably on the CT scanner for about 5 minutes. And the other nice thing about it is you do see about 2/3 of the lung fields. So sometimes you may find some unsuspecting cancer. And of course, we can have a discussion, just like with breast cancer, is finding it early make a difference. This is what a calcium scan looks like. The radiation exposure is really small. It's a millisievert of X-ray exposure, increase the lifetime risk of a malignancy by like 0.005%. Number needed to expose to a calcium score to really induce harm is 1 in 20,000. So it's a really safe test to do. We don't. If you ask somebody, well, how many X-rays does that mean? That's kind of a fake approach, because X-rays really are pretty innocuous, unless you forget to push the off button. But it's quite innocuous, and it's a very efficient scan. If you want to look at some of the radiation absorption by these different testing, I think you can see that, relatively speaking, the exposure is quite modest. So in diabetics, it's actually useful in terms of defining mortality by virtue of the calcium score. So you can see a low calcium score, and as you get calcium scores that are higher, you can actually somewhat risk stratify in terms of mortality rates in the diabetic. This is also very interesting. This is looking at patients who would meet or not meet the indication for statin use. So this is the patients based on the 2012 ESC guidelines. This is looking at the 2013 ACC-AHA guidelines. Here we're looking at coronary events, and here we're looking at all cardiovascular events. Now what's interesting, if you look at the patients who would not have an indication based on algorithms in these protocols, you actually identify patients that would not necessarily be recommended treatment with a statin by virtue of the calcium score. So these are the patients that you would want to treat with statins, et cetera, and perhaps in contradistinction to what the guidelines would say. So it really does add to the ability to prognosticate in terms of coronary and cardiovascular events above and beyond, the risk, a clinical risk assessment. And again, I think that's the important thing, is that we really do, in a way, allows us to be a lot more specific and sensitive in terms of our approach to patients at risk for cardiovascular disease. Big aspirin controversy, right? I have all my patients now asking me, Dr. Lepor, they're calling me like crazy. That's why I hired Simone as my nurse practitioner. I was getting way too many phone calls, and I wasn't smart enough to answer a lot of these questions. And everyone taking aspirin would say, I heard on the news that I don't have to take aspirin anymore. Well, that's really not true. If you don't have plaque or you haven't had a cardiovascular event, you don't need to take aspirin. And there are many people, so it's not very good for primary prevention. But my definition of primary prevention isn't just event-driven, it's also imaging-driven. It's because, why should I wait until the patient has an MI to define the event? Because the mortality associated with an MI is about 50%. So this is the threshold, what's called the number needed to treat, which would be considered reasonable. So if you really have a calcium score of 0, even if you have a high risk by virtue of your risk calculator, you're considered low enough risk that the risk-benefit is not consistent with a positive benefit. I tell my patients that basically I'm a bookie. So why am I a good doctor? Because I'm a good bookie. Because I kind of do what they do with the horse races. Does anyone bet on the horses here?
Do the odds.
Who bets on horses? So when you bet on a horse, what are you looking at? What kind of characteristics are you looking at? Yeah, sure.
I look at the book and say which one's, you know, kind of borderline
Uh-huh.
hit, and I go for that one.
I know
To show, to show.
So some people say, well, is it a wet track? Is it a dry
I don't
track?
go with that.
You know, did they give the horse diuretics? So, so what we see here is even in those, here you have these patients with calcium scores over 100. You can see how, you know, and even in those that you would not necessarily make a recommendation for the use of aspirin, you know, you can even risk stratify using calcium scoring that population.
Dr. Lepor,
Yes.
I'm just going to stop you there because I get so many questions about this too. So if somebody is positive, can you go back one slide? Is that possible?
Mhm.
So in that graph, you would say all those people with the CAC 0, no aspirin.
Right.
And then what about the 1 to 99 and the greater to 100?
Okay, so let me just say two things. So before I say no aspirin, I look at the coronary anatomy and the carotid anatomy. Because, you know, as Carol knows well, the different arteries to different organs are different organs themselves. So, for instance, we know the first sign of disease, vascular disease, is in the iliac bifurcation. So, and if you smoke, you tend to get more peripheral vascular disease. So, what we like to do before we say you don't have plaque is to look at two circulations. Okay. So, what this says is there's two ways of risk stratifying. One is the clinical parameters. So what they're saying, if by clinical risk assessment, you're lower risk, and if your calcium score is 0, there's no need to, unless there's disease in another circulation. And what this also says is that the clinical scenario does make a difference. So you have a patient with a small amount of calcium, but they're low risk by virtue of their risk assessment, then that patient is still relatively safe, and that may be a patient who you don't have to use aspirin therapy. So what you're doing, you're combining your clinical assessment with a imaging assessment to make that definition. I mean, if the patient, because what it's saying, if your clinical risk is low, that means you're probably not hypertensive, your lipids are okay, and you're probably not too old, because we know that risk assessments are very age dependent. Basically, if you're 80 years old, you know, you're going to be high risk, even if you don't have these comorbidities. So I think it's a combination of using a clinical assessment. But what this does say, if your calcium score is over 100, it doesn't really matter what your clinical risk score is. That patient would benefit.
That is so helpful.
Okay.
Thank you. I'm glad we got that because one of our doctors keeps asking that question up north, and maybe we'll have you come speak up there too. Thank you.
Mhm. This is the recommendations of the different societies in terms of the use of the implications of, or when you should consider using coronary calcium scoring. What they're saying is that, you know, and again, we all know the recommendations are based on clinical criteria, based on economics, and some non-objective criteria. But what they're basically saying is if you're low risk, there's really no need to do a coronary calcium score. Now, as you approach these intermediate scores, that's where I think calcium scoring can certainly reclassify a patient in terms of risk. So this would be a patient population generally where you consider statins, but it's not a patient population where you actually will strongly urge. This is where you're supposed to talk with the family and, you know, engage them. But even this population of high risk, this would be very high risk. In this very high risk patient, in this high risk patient cohort, if the calcium score is 0, okay, generally statins would be recommended. But if the calcium score is 0, what you've been able to do again is to add more specificity to the assessment, and that patient may not need to be on a statin. Yes.
In your third column there, how likely is it for someone to have, say, a risk of 10% and to not have any calcium?
I can't give you a percent. I think that's probably available, but I can tell you it happens clinically enough that it does have an impact. These aren't rare events.
It's not a unicorn.
Pardon me, it's not uniform. Remember, calcium scoring is not uniform itself in
I'm
terms.
sorry, it's not a unicorn.
A unicorn.
A unicorn? No, I'm sorry. Yeah, it's not a unicorn.
Right.
And I think that this has most. You know, this has the highest impact in those patients where the ACC/AHA recommendations at 40-75. You don't have to do calcium scoring in a 90-year-old. patients, unless you want to stop their statin. You know, if a 90-year-old has minimal calcium, you can say, hey, this person's not going to die from cardiovascular disease, so, but I don't think that's the patient. And if you're high risk, basically if you're very high risk, calcium scoring isn't going to impact your decision. So if you really have a very high risk, if you're very high risk or you're very low risk, probably not necessary to do calcium scanning on a population wide, but if you're intermediate and high risk, I think that's where coronary calcium scanning is quite helpful. And these are the recommendations. The Europeans are actually much more assertive. Anyone here from the U.S. Preventive Services Task Force? You know, I just don't like any of their recommendations. You know, my brother is a world famous prostate cancer urologist, and so when they